Okay, examination of the cranial nerves usually starts with the examination of the olfactory nerve. The steps for the olfactory cranial nerve examination will be just like this. First of all, I'll make sure that the patient had patent nasal passages via a cotton. With each nasal passage, I'll ask the patient to just like this. Okay, so it is patent this side, and also for this side also it is patent. After that, I'll ask the patient to close his eye, and I'll use a test substance. Okay, I'll use these two tests. First of all, I'll use tobacco, cigarettes, and then I'll use a soap for the patient to check. اوكي حماده هسه راح اخلفت شيء مخشمك تشتمه وتقول لنا شنو هو. اشتم منه. اوكي شنو هذا اللي خليناه؟ صابون. هذا صابون. اوكي هسه هذا شنو؟ جقاير. Okay, so the patient's ability to recognize the odor was perfect. And the testing of the olfactory nerve, we have to know whether the patient had inability to smell, what we call it anosmia, or the patient had decreased ability to smell, which is called hyposmia. Other abnormalities may take the form of dysosmia and parosmia. Dysosmia, instead of smelling of good odor, the patient will recognize bad odor, and this condition had many pathological causes. And the last one is what we call the parosmia, which is a hallucination. That's to say, the patient falsely will smell an odor in the absence of that odor. Also, the candidate should know the causes for these abnormalities. The second cranial nerve is the optic nerve. In the assessment of the optic nerve, one should assess the visual acuity, the visual field, color vision, and lastly ophthalmoscopic examination. Really, ophthalmoscopic examination is mainly designated for postgraduate candidate, and the color vision need Ishihara test or Ishihara plates. In the first step, in the assessment of the visual acuity, we have to the following points. First of all, if the patient is wearing glasses, we have to keep them, and we will ask the patient to provide us with the number that is seen upon the Snelling chart. This Snelling chart is 6 meters distance from the patients, and this is about the visual acuity. If the patient was unable to read any letters at that distance, we can assess his poor vision in the following manner. First of all, I'll check the calculation ability, and remember that each eye should be checked separately. حمادة هسه سوي من ايدك هيجي وتصم لنا عينك هذا منها. لا سوي لي بهاي ايدك وصم لنا هاي عينك. هسه تباوع عليه انا راح اسوي لك فد ارقام بايدي وتقول لي يعني ايش قد. اوكي ايش قد اني 4 3 اوكي. If the patient was unable, this is just a demonstration, this is not a real exam. If the patient was unable, I'll assess just the finger perception, whether or not the patient was able to perceive fingers. هذا شنو؟ Okay, this is just to assess whether the patient was able to perceive finger or not. If the patient wasn't able to perceive these fingers, I'd really use light perception in the following manner. هسه هذا شنو؟ Okay, يعني ايش يجي على عينك هسه؟ Okay, the patient, as I said to you, he is a volunteer, not a patient at all, and he is able. But at the time of a clinical examination or clinical training, you have to check for that. And instead of a Snelling chart, we can also substitute or can give an order to the patient to read a number, for example, a far number, or we can provide him with number made from your finger from a far distance, and you can come up to the patient to assess him. After that, you have to check the other eye. this is what we call it the visual acuity assessment, and then we have to check the visual field. In the visual field assessment, you have the following 4 steps. First of all, you have to check whether the patient had sensory inattention or not. That's to say, when a patient who had non-dominant parietal lobe lesion, he will have what we call it the neglect or sensory inattention, and I'll check the sensory inattention in the following manner. This step, the only step in the examination or assessment of the visual peripheral or the visual field in general, that needs both eyes to be open in the following manner. هسه تباوع لي حماده، فاتح عيونك تتباوع علي. هسه أنا خليت دي اثنيناتهن. هسه اريدك يا اصبع اللي راح احركك وتقول لي اياه. هكذا هنا اوكي. هكذا هنا اثنيناتهن اوكي. 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 Okay. Why I perform this test? Really, this is just to test whether the patient had a gross inability to perceive the waggling finger. Patient who had a non-dominant parietal lesion, he is or she is able to recognize the waggling finger when individually moved, but he will neglect one side when both of them are moved. This is really just to assess the gross visual field defect. After that, I'll check the central visual field. Central visual field, we usually use a red hat pen, and we have to know that the central visual field extends to 30 degrees from the central fixation in all direction. That's to say, if I see the patient laterally, I can assess that the central visual field up to this level and up to this level. Yes, just like this. This is the central visual field. I'll assess 2 quadrants above and 2 quadrants below. The same thing. This quadrant we call it nasal, upper and lower, and these quadrants are called temporal quadrants, also upper and lower. In the following manner, I'll ask him about. At each step, you have to check whether the patient had color saturation or not. That's to say, changing of the color instead of red into pink or pale. هسه حماده. Okay, I'll be about 1 arm from the patient. هسه صم النهمات هاي عينك. Okay, أنا راح أصم هاي بقبالك. هسه اريدك تباوع لنا. هسه هذا لونه شنو؟ هذا أحمر. Okay. هسه لا تباوع لي مباشرة على عيني وأنا وياك خلينا نشوف. هسه هذا اللون شنو؟ أحمر. هذا اللون شنو؟ أحمر. هذا اللون شنو؟ هذا اللون شنو؟ Okay. I ask him about the color because any color saturation indicate central visual field defect, also in the form of nasal and temporal quadrant. After that, since the patient had taken this position, I'll check for a blind spot. A blind spot really, for this eye for example, I'll move also the red hat pen about 15 to 20 degree temporal from the central fixation. This is the central fixation between him and me. About 15 to 20 degrees. He and me will be unable to see the color of the red hat pen for 5 degrees. Just for 5 degrees. I'll check for that in the following manner. هسه أنا هماتن راح أخليها. هسه هذا شنو هو؟ لونه أحمر. هسه تبقى تباوع لي من يختفي اللون عندك الأحمر تقول لي تتباوع لي. هسه اختفى شلون لونه تقريبا صار يميل للسواد. عافية. هسه من يرجع النوبة تقول لي هسه okay. If the patient here wasn't able to, or he was able to recognize and I wasn't able to recognize, I can change the position of the red hat pen. This area exactly this to me. هسه تشوف لو ما تشوفه. اوكي. هسه اوكي. خلينا نرجع إليها from the central fixation. هسه تبقى تباوع عليه، تبقى تباوع عليه، من يختفي عندك عود قول لي. هسه ما تشوفه. اوكي هسه رجعت تشوف. اوكي so this distance, about this distance, this is 15 to 20 degree. This distance between me and him, his vision had been superimposed upon my vision. شكرا. And we check the blind spot. Real enlargement of the blind spot had many pathological conditions. After checking this eye, you have also to check the other eye. This is about the sensory attention, central visual field, and the blind spot assessment. After that, you have to check for the peripheral visual field assessment. Really, the peripheral visual field assessment, we have to have an idea about the field, how much is. The field extends about 130 degree vertically for monocular vision, and horizontally about 160 degree. Also, we will check it in 4 quadrants, 2 superior quadrant and 2 inferior quadrants, and we will classify the quadrant of each eye into, for example, here I'll check the right eye into superior nasal, inferior temporal, and superior temporal, and I'll check for waggling finger. Also, when his peripheral visual field had been superimposed upon my peripheral visual field, also in the following manner, I'll be also at about 1 arm length from me. I'll ask him to close one of his eye. هسه منهم نفس الحالة هاي عينك، وأنا راح أصم هاي عيني، وأنا راح أحرك أصبعي. أوكي بيني وبينك، من تشوف الأصبع التنو بتقول لي أوكي، من تشوفه يتحرك دا تشوفه. هسه هماتين دا تشوفه. أوكي هسه من تشوفه الأصبع هماتين تقول لي اوكي دا تشوفه. اوكي هسه هنا من تشوف الاصبع بيني وبينك، هسه اني من تشوف الاصبع دا يتحرك هماتين تقول لي اوكي دا تشوفه. هسه هنا من تشوف الاصبع هماتين من يتحرك هماتين تقول لي اوكي دا تشوفه. اوكي both for quadrants are assessed. هسه صملنا هاي عينك هاي ايدك، انا هماتين راح اصم هنا بنفس الحاله، هماتين راح تشيك بيني وبينك، من يتحرك تقول لي اوكي اوكي Okay, that shows. So I check, for example, for this eye, superior temporal, inferior temporal, inferior nasal, and superior nasal, upon which you can check whether the patient had hemianopia, that's to say, he had half of his visual field being lost, or quadrant anopia, that's to say just quadrant from his visual field is lost. And after that, you can interpret the finding into many or a variety of clinical condition and pathological condition. The third, this is just about the visual field. The third step, as I said, is the assessment of the color vision, and we have to have an Ishihara plates. And the fourth step, the ophthalmoscopic examination, which is mainly designated for postgraduate students. The further assessment of the cranial nerve examination include assessment of the third cranial nerve, fourth cranial nerve, and sixth cranial nerve. This cranial nerve can be examined together, which is the usual clinical training sequences or technique, and or can be examined individually, as I will show it just a few moments later. Really, if they are examined together, we have the following 3 steps, and each step is subdivided further into 3 findings or steps. The first step is a prime position. In the prime position, check whether the patient had proptosis, ptosis, or pupillary inequality. This is the first step, prime position. The second step is to perform the H test. From the H test, you can note whether the patient had any nystagmus, ask him about any diplopia, and note whether the patient had any limitation of his extraocular muscle movement. The third step would be the pupillary reaction to light, both direct and indirect, and lastly the accommodation test. I'll show the sequences of examination the following manner. First of all, I'll check for a prime position. I'll put a pen in front of the patient. هستباوع على هذا القلم to see whether the patient has ptosis, proptosis, and I'll check for pupil whether they are equal, symmetrical or not. This is the first step. This is the prime position. The next step would be the edge test performance. I'll check for the findings in the following manner. حماده هسه شريدك هسه تباوع لي تباوع القلم. وين ما يروح القلم اريدك تحرك عيونك وياه بدون راسك، بدون حركة راسك، فقط القلم تحركه. هسه هنا اوكي، هنا اشتدك، هسه هنا، هسه ترجع للنص. هسه راح اشيك لك هاي الجهة، تباوع لفوق هنا، عفوا، هسه تباوع لهنا، هسه راح ارجع لك للنص. اوكي، اكو شفت عندك القلم صار صورتين بأي منطقة من ضمن المناطق تشيكناها نهائيا ما صارت. So I'll notice whether the patient had any limitation of extraocular muscle in the eye movement or any nystagmus, and I asked him about diplopia. Really, nystagmus oscillation of the eyeball of the eye, and it is of two types, either jerky or pendular. Jerky is classified into vertical nystagmus and horizontal nystagmus. Vertical nystagmus can be further classified into upbeat nystagmus and downbeat nystagmus, and so on. If the patient had diplopia, we can further assess it later in the form of cover test. Really, these are the edge test examination. After that, I'll check the reaction of the eyes, or mainly the pupil, in the form of direct and indirect in the following manner. I'll check this eye. هسه تتبقى تباوع لهيجي. Okay, so the pupil is reacting. This is for the direct. The pupil became small, and I'll see the other pupil while I am shining the light for this eye. After that, I'll check also the direct for this eye. Okay, and to see how much it is constructed, and then the indirect by shining a light here and to see the constriction here. Okay, after that I'll check for the accommodation test. I'll ask the patient to look for a far object and then to look at an object with about 5 inches from the eyes of the patient. هسه بدك تباوع على الطرف مال الغرفة، تباوع عليه. هسه تباوع على القلم. Okay, the patient had the triad of ptosis, convergence and meiosis, so he had accommodation test is intact. Really, sometimes when the patient had what we call it afferent pupillary defect, we can use swinging light test in the following manner. The swinging light test, just like this, shine the light here and then immediately here, and to see the pupillary size with the direction of the light. Normally, when I direct, for example, the light here to my left eye, I'll see that the pupil is constricted, and also indirectly this pupil will also be constricted. This constriction here is more stronger than the constriction here because it is direct. Also, when I check this eye, I'll see also narrowing or constriction of my right pupil, also a little bit stronger than the constriction here. Swinging light test is designated just to assess whether the patient had Marcus Gunn pupil or not. Marcus Gunn pupil mean afferent pupillary defect, that's to say the optic nerve is affected. Those who had optic nerve defect, they will show dilatation instead of constriction. Why? Because the light reflex is subserved via the optic nerve as an efferent and the third cranial nerve as an efferent. So if I have a defect here, for example, in my left optic nerve, when I shine the light here, I have afferent pupillary defect. That's to say, though, there is no reception. So the eye, especially if it is blind, so the eye will never constrict it. Okay? When I shine the light to my right eye, there will be constriction because it is the indirect reaction. Comes from the third cranial nerve which supply both eyes. When I immediately shine the light upon this indirectly constricted eye, it will be dilated instead of constriction. This paradoxical dilatation instead of constriction is called Marcus gun pupil. Really, these are the steps of the examination of the third oculomotor, trochlear and abducens nerve. Sometimes the examination may include questions about assessment of cranial nerve individually. If the question was to assess third cranial nerve individually, you have to perform these three steps: prime position, edge test, and the reaction, light and near accommodation reflex. If the question was to assess the fourth cranial nerve, you have to perform the first of all prime position, this is one, and then to assess edge test, especially this movement. If for example this eye had defect in the fourth cranial nerve, especially for this movement, bring the object in and especially down. Ask the patient to look at it from outer into in and especially down for the fourth cranial nerve, especially this step. And then this is for the fourth cranial nerve, is to perform Bolshevsky test. Bolshevsky sign or Bolshevsky test is designated is to see whether the eyes became parallel to each other with tilting of the head or not, because patient who had fourth cranial nerve defect, for example, in this eye, he will tilt his head into the contralateral or opposite shoulder to get more parallel eye. Okay? Because the defect here in the superior oblique, so his eye will be a little bit higher than this eye, and to bring both of them parallel, he will tilt his head into the opposite shoulder. We can perform Bolshevsky test in the following manner. I'll see both eyes and then tilt it like this and then tilt it like this, and to see how much it is corrected, whether it is corrected or not. These three steps for the fourth cranial nerve, and the sixth cranial nerve also by prime position and by performance of the edge test, especially the outer parts, because the lateral rectus is supplied by the abducens nerve. All these issues are about the examination of the third, fourth, and sixth cranial nerve. Okay, regarding examination of the fifth cranial nerve, which is the trigeminal nerve, we will test the sensory function, motor function, and then we test the reflexes in the form of corneal reflex and Rajooj. First of all, we will touch sensation using a wisp of cotton. This is for light touch, crude touch, asking the patient to close his eyes and touch. سد عيونك. Touch really here above. تحس بيها هسه هنا. اوكي هسه هنا. اكو مكان يختلف عن الثاني او اقل او اكثر. اوكي هسه هنا وهنا. Okay, you have to test for the ophthalmic division here and above, and here for maxillary division here, and here for the mandibular division. So we have ophthalmic, maxillary, and mandibular division. This is all about the crude light touch. And then you have to use the safety pin for pain testing. هسه افتح لنا عيونك. هسه حاليا هذا راح اخليه يطف وتحس انه ياكل اقل اكثر او ما تحس به، سد من عيونك. also check ophthalmic division. هسه تحس به، هسه حاليا أقل أكثر، هسه نفس الشيء، هسه هنا أقل أكثر شيء ماكو. أوكي افتح من عيونك. Really all issues about the decrease or increase in perception or absence of perception will be described later. This is about the sensory function. After that I'll check the motor function in the following manner. I'll see the patient and inspect for the masseter, for the temporalis muscle above the zygomatic arch, and here the muscles of mastication, masseter muscle. After that I'll ask the patient to clench his mouth to check the bulk. This is the bulk of the masseter muscle. Then ask the patient to open his mouth. هسه افتح لنا حلقة. حل افتح لنا على كيف هسه. To see any deviation, and after that ask him to open his mouth but against resistance. هسه راح أنا أسد حلقة وأنت افتحها. Okay. عشتيدك. To see the against resistance, to see whether there is also any deviation in the mouth or not. Usually, or if there is any trigeminal nerve lesion, the direction or turning of the mouth will be directed toward the affected side. After that you have to check for the jaw in the following manner. Ask the patient to open his mouth a little. هسه تفتح لنا حلقك بس مو كلش قوي. And put your thumb here at the chin and tap it. Okay, this is about the jaw jerk. You will see that the patient had either there is contraction or no contraction at all, and this is normal. If the patient had exaggerated closure of the mouth, this may indicate bilateral upper motor neural lesion of the trigeminal nerve in the form of pseudobulbar palsy. After that, and lastly, you have to check for corneal reflex. Use a wisp of cotton, and you have to warn the patient that you are gonna touching his cornea, and touch the border of the cornea, not the conjunctiva, and see the response, which should be bilateral blinking. هسه حماده هذا راح اخليها تضخ بعينك، ماكو مشكله. هسه بدك تباوع لي لفوق هيك شيء قليل، بس هاي تضخ بعينك. Okay, see bilateral response. After that check the other side. Okay, this is there is bilateral response. If the patient are skittish or afraid from this touching, you can make a little glue over his eyes in the following in the following manner. Also you will see that there is bilateral blinking. Really, in the interpretation of the corneal reflex, we have to know that this reflex is mediated or conducted subserved via the afferently by trigeminal nerve and afferently by the facial nerve. We have to know if the patient had unilateral trigeminal nerve palsy. Blinking in the same side will produce no response because it is the afferent that is affected. If the normal side is stimulated, there will be bilateral response. This is about the trigeminal nerve. About the facial nerve, if the patient had unilateral facial nerve palsy, for example here, if you stimulate this side, there will be no blinking in the same side because the afferent is affected, and the normal side there will be a response. If the normal side now is stimulated also, the normal side there will be blinking, but there will be no blinking in the contralateral affected side. If the patient had bilateral facial nerve palsy, there will be no blinking whether you stimulate the normal side or abnormal side. All these issues and steps are about the examination of the trigeminal nerve. Okay, regarding the examination of the facial nerve, really in the examination of the facial nerve we have a rule in clinical training, which is 4+ tests. First of all, the 4 tests, which is the initial test, whether the patient had upper or lower facial nerve palsy. First of all, I'll look at the wrinkles and at the nasolabial fold here. Then I'll perform the following tests. First test, I'll ask the patient to raise his eyebrow. هسه بس حمالة ترفع عنا هيك عيونك. Okay, to see here the wrinkles, frontal wrinkles here and here. Okay, هسه نزل عينك. هسه تصم لنا عيونك وكأنه بين صابون. حل هيك تصم لنا اياها. Try to open it. Normally I can't. Okay, normally I can't. هاي عشتدك. After that I'll ask the patient to show me his teeth. هسه هيك هسه بدي اشوف اسنانه. بعد. Okay. To see any deviation. This is the nasal labial fold. To see any deviation. عشتدك. هسه تنفخ هيك. Okay, and I'll check whether there is any air escaped from the mouth or not. عشتدك. Well, from these 4 tests, one should now decide whether the patient had normal facial nerve examination, just like our volunteer, or the patient may have an upper or lower motor, upper or lower facial nerve palsy. Really, how can we differentiate between them? If the patient had no wrinkles, for example, for this side, if the patient had no wrinkles, unable to close this eye, and the nasolabial fold here is lost, so the patient, because he had involvement of the upper half of the face and lower half of the face, this is lower motor facial nerve palsy. If the patient can close his eyes, had wrinkles here, but the nasolabial fold is lost and he had deviation in the corner of the mouth, this indicates upper motor cranial nerve, because the upper half of the face had bilateral innervation while the lower face had unilateral innervation. At this moment, after you decide whether the patient had an upper motor neuron lesion or a lower motor neuron lesion, you have to add the plus test. Really, if the patient now had upper motor, I'll ask the patient to whistle. Really, every patient, every person, when they ask, especially at this situation, when they ask to whistle, they will smile, just like I'll perform it, or I'll ask our volunteer about this. هسه بس حمالة تقدر تصفر. Okay, the patient start to smile. This really reflects the subcortical pathway of the facial nerve together with the step of show me your teeth, which was cortical. We can differentiate whether the patient had cortical or subcortical, just subcortical affection or just cortical affection. This is with respect if the patient had upper motor neural lesion. If the patient had lower motor neural lesion, what are the plus tests? First of all, I'll check the external ear for vesicles, the external auditory meatus. Check it for vesicles, which occurs in Ramsey-Hunt syndrome. After that, we have to, which is non-routine, to check the tears in both eye, lacrimation, via Shermer's test, which is non-routine, I said. And then we have to check for hyperacusis. Hyperacusis, just like this. We have to close the tragus here. And I'll rub my finger, or you can whistle a number. سمعت هذا. I'll close this side and I'll perform the same here. سمعته؟ يا هو الأعلى أكو مكان أعلى نفس الشيء. اثنين هذا نفس الشيء. Okay, if the patient had hyperacusis, he will listen to the sound and hear that the sound is higher in one side than the other. This is hyperacusis. And then we have to check whether the patient had salivation also. This is non-routine. And we have to check whether the test ability is perfect or not. Really, in testing ability, we have to check for salt, we have to check for the sour material, we have to check for the sweet material, and so on. But really, I'll use just sugar here I brought with me. I'll ask the patient to protrude his tongue, not to talk during the test, and to close his eyes so as not to see the testing substance. حماد هسه بس راح اقول لك الاتي. تصم لنا عيونك، تفتح لنا حلقك وتطلع لنا لسانك لبرا. راح اخلي فد شيء عليه، اريدك تحس شنو هذا الشيء. اوكي يلا صم لنا عيونك. اوكي افتح لنا حلقك، طلع لنا سنونك، طلع لنا لسانك لبرا، عفوا لبرا بعد. اوكي I'll use just one side. اوكي لا تخليه، لا تدخل لسانك من اذا اوكي قدرت تحس بالطعم. اوكي هسه افتح لنا عيونك. ايه اوكي شنو هو شكر. اوكي so the patient can really recognize the test substance. This is really important because we have to localize the lower motor neural lesion. Really the facial nerve is very important to know about it, and the candidate should know also whether the facial nerve is accompanied by lesion in the Abducens nerve, which indicates that the lesion is in the bones, or the patient had trigeminal nerve in addition to the Vestibulocochlear Nerve, which indicates that the lesion is at the CPA angle, and so on. If the patient had hyperacusis and loss of lacrimation, saliva and taste, or if the patient had intact lacrimation with the lesion or the inability to recognize the substance and so on, really the candidate can consult his or her textbook of examination to localize the lower motor neuron lesion. Okay, regarding the 8th cranial nerve examination, the vestibulocochlear nerve, really we will, because of this cranial nerve consists of two components, so we will check the hearing ability of the patient and the balance ability of the patient, the cochlear part and the vestibular part respectively. First of all, really roughly during the clinical examination, if you would like to check the patient ability to hear, either to whistle a sound in the patient ear or to rub your fingers. هسه تصم لنا عيونك حماده. شنو سوينا هسه احنا؟
صوت
ايش بيه؟ اوكي عشت يدك. هسه راح اصم هاي اذانك. هسه شنو هو؟ اوكي. This is just a rough assessment, rubbing test, just rough assessment, and the best افتح لنا عينك عشت يدك. And the best assessment via the Weber test and Rani test, really, which both of them are not part of the routine examination. After that, I'll check the vestibular components of the nerve via what we call it the Dix-Hellpike test. Really, the Dix-Hellpike test is also a routine test, but sometimes it is inquired from the candidate. I'll perform it just like this. First of all, I'll make the patient in the middle. هسه تقدر تبقى هيك بس ظهرك عليه. يعني تقدر تمد رجليك ما في مشكلة. قاعد تتقدم لقدام تبقى اوكي عشت يدك. Okay, first of all, I'll grasp the patient's head. I'll lower it down. على راحتك حمادة. I'll lower it down up to 30 degrees below the horizon and make the eyes باوعلت toward me. The lower part of his head is the right ear, and I'll wait for 20 to 30 seconds to see any nystagmus, which if occur, that is due to benign positional vertigo, last also just few seconds and then became fatigued. After that, I'll return back the patient and I'll perform it on the other side. Also, I'll wait for 20 to 30 seconds. Okay, after that, I'll make the patient sit. This test is really designated. This test is really designated to check whether nystagmus can be elicited or not. If it is fatigable, if had a latency and just a few periods, most likely cause is benign positional vertigo, while if it is non-fatigable and persistent more than this time, one should think about other causes like brainstem or cerebellum. This is really in brief the examination of the vestibulocochlear nerve. Okay, now regarding examination of the 9th cranial nerve and 10th cranial nerve, these nerves are usually examined together, both the glossopharyngeal nerve and the vagus nerve. The following step: first of all, I'll ask the patient about his deglutition swallowing. شلون بلعك حماته؟ زين إن شاء الله. أكو عندك صوب بالبلع شيء. Okay, if the patient had swallowing difficulty, this may indicate involvement of the vagus nerve, especially only when it is oropharyngeal dysphagia. And also I had listened to patient speech whether it is dysphonic or dysarthric. After that I'll assess the swallowing ability of the patient via drinking water or via an alternative test. Regarding the alternative test, just like this, السحم هذا بس ريدك تنفخ هيك حيل and to check whether the air is escaped from his nose or not, and to hear about it. هاي عشتي because patient who had affection of his palate due to vagal nerve damage, he hadn't the ability to perform this test, or I'll ask him to swallow water. We can provide him with water. هسه بس نريدك تشرب، راح نعطيك مي ونشوف بس البلع مالتك شلون تشرب. حاليا اشرب. شلون ابلعك هسه؟ كمل شربك. أنا عشتبك. Really about just the swallowing test, some suggest it is advisable to use a spoonful, just 3 spoonful, and to test the ability of the patient, and after that to check whether the patient had cough or any change in his swallowing occur. Or this test would suggest that a large amount of water is to be given, and when the patient is swallowing we have to disturb him by asking him about his or her swallowing, because the patient may make small chunks of fluid and keep it inside his mouth and then swallow it without any obvious evidence for this difficulty. Anyhow, this is the next step in the examination of the of both these nerves, and after that I'll ask the patient to open his mouth and to look at his uvula. افتح لنا حلقك قوي كلش. Okay, to see the inside of the mouth, and I'll ask the patient to say قول to see the uvula that is movable. عشت ايدك بعد قول لنا. And to see the sides here. عشت ايدك هاي على راحتك. After that, really, I would perform the gag reflex and then the sensation. Really, these tests, especially gag reflex, need permission from the examination committee. Most of the current textbook had omitted this test, but you have to check it, or to at least to take a permission to perform such a test. If we perform such a test, we have to warn the patient that we are going to perform such a test, because it is undesirable for many patients, and to see the response. The response will be just like the initial response of vomiting. The patient will have contraction, retraction in his mouth, contraction of the pharynx with the elevation of the uvula. Each side of the posterior pharyngeal wall should be checked. That's to say, I'll check the gag reflex initially at the left side, for example, then I'll check it at the right side, and to compare between them. But as I said, this test had been omitted in most of our clinical textbook. هسه حماده بس هذه راح اطخها ببلعومك. اوكي ماكو مشكله. تفتح لنا حلقه. اوكي I'll lower the tongue. لا على راحتك. نزل. اوكي I'll test. Okay, just like this. I can't. هاي عشتي. Okay, I'll omit the other, because this is just a demonstration. I'll omit the other side. Just like this movement, just like the initiation of vomiting, is considered as positive, you have to check also the other side. After that, you have to check the sensation in the posterior pharyngeal wall. Also, you have to check each side and compare it with the other side. تفتح لنا حلقة بس بدك تقول لها تحس بيها ولا لا؟ تحس بيها؟ اوكي هسه هنا أنا تحس بيها عشتك. Okay, he had a sensation. These steps by which you can consider whether the patient had any defect in both this nerve or had defect in the vagal nerve, and the causes for this lesion of this cranial nerve. Also, the candidate should be carefully looked for the causes of this cranial nerve damage. Okay, regarding the hypoglossal nerve examination, which is the 12th cranial nerve, really this nerve will be checked in the following sequences. First of all, I'll ask the patient to open his mouth, and I'll look really at the tongue in both sides to see whether there is any fasciculation or wasting. Really, as we said previously, the 10th cranial nerve and 7th cranial nerve the same with respect to the deviation, and the 5th cranial nerve and the 12th cranial nerve is the same. The latter will be deviated toward the affected side. After that, I'll ask the patient to protrude his tongue, بالله طلع لنا لسانك لبرا, and to see also an obvious wasting or any tremor, and to look at the size, the vertical distance, the vertical depth. After that, really, we will check the bulk of the muscle via the following maneuver. هسه من داخل حلقك بلسانك وتضغط أصابعي. أنا عشت إيدك. هنا عشت إيدك. Really, why this test the bulk of the muscle and the strength of the muscle of the tongue. Really, when we have just one lesion, one side affected, there will be unlikely to be an upper motor neural lesion. It is most likely lower motor neural lesion, so there will be wasting and fasciculation, and this will be obvious. When they are bilaterally affected, which is common, especially due to bulbar palsy or pseudobulbar palsy, when they are bilateral affected due to upper motor neural lesion, this condition may occur in pseudobulbar palsy, and we will see that the vertical depth of the tongue will be increased. So the posterior pharyngeal wall will not be seen, or just a small distance or space can be seen from. While a patient who had bilateral lower motor hypoglossal nerve palsy, in case of bulbar palsy, we will see that the tongue is atrophied, and a wide area from the posterior pharyngeal wall will be visualized. This occurs, as I said, in bulbar palsy. And really, the term pseudobulbar palsy and bulbar palsy is very important to be contrasted and notified, which means that the lower cranial nerve, especially the 9th, 10th, 11th and 12th, are bilaterally affected. If the process is that of lower motor neural lesion, this is what we call it bulbar palsy, while if it is due to bilateral upper motor neural lesion, this process is called pseudobulbar palsy, and we have differences in the form of jaw jerk and the speech and so on. The candidate should also carefully look for the causes and the feature of both of these clinical conditions. Really, the examination of the 11th cranial nerve, the accessory nerve, consists of the following. First of all, we have to check both trapezius muscle by asking the patient to shrug or elevate his shoulders. بس ترفع حيل قوي. هاي عشتيتك to see the strength, and after that I'll see the sternocleidomastoid. هسه تضغط لنا على ايدي هاي حيل قوي قوي حيل قوي and to see this is the sternocleidomastoid. The other side also should be checked. هسه على هاي الجهة حيل قوي. This is the sternocleidomastoid. بالك هاي عشتيتك. Really, in the interpretation, we have to know that the right sternocleidomastoid will deviate the face toward the left. Likewise, the left sternocleidomastoid will deviate the head to the right. In the interpretation, one should know the causes of bilateral trapezius and sternocleidomastoid, which usually due to motor neuron lesion or myopathy, or the patient had the same side, trapezius and sternocleidomastoid, which is usually due to peripheral neuropathy, or the patient had the sternocleidomastoid here and the trapezius here, especially if it is accompanied by hemiplegia here, or ipsilateral to the sternocleidomastoid. This indicates an upper motor neuron lesion. This is, or these the steps of the examination of the accessory nerve.